Susan Kelly, president of the club. Welcome to City Club and another special program, this time focusing on an ever-increasing problem, the numbers of Oregonians and Americans who do not have and cannot afford to obtain health care insurance. Our guest speakers today are Barney Speight, Director of Public Policy for Kaiser Permanente, and Alice Dale, President of Service Employees Local 49. Alisa Brake, our third speaker, is not able to be here due to a family illness. On Friday, March 21st, join us for our second State of program this year as we focus on the current status and future of Metro. New President of the Regional Government, David Bragdon, will be with us to share his perspective and plans for the future of Metro. Our annual membership drive is well underway. We're at the halfway point to our 100 new member goal. Oh, 1,000, woo! You'll find okay, that's a challenge. You'll find membership information on your tables. I urge you to pick up an application form and become a member of this dynamic organization today. Our board host is Corleen Kraft, member of the Board of Governors and realtor with the Hassan Company, and she will ask the first question of our speakers. Following Corleen's question, we'll open the program to questions from City Club members in the audience, specifically to Ted Falk from the Health Issues Committee. First, please line up behind the microphone even before Corleen and Ted are finished so that we have time to have as many questions as possible of our guest speakers. This is a City Club privilege, and if you decide today to sign up, fill out that form and you may ask a question. Keep your question to 30 seconds or less. Broadcast of City Club programs this quarter is made possible in part by corporate underwriting from Kaiser Permanente, Nike, and Washington Mutual. We are very grateful for their support. Today's program is presented in conjunction with the local Portland activities for the Covered the Uninsured Week, which is March 10 to 16. This is a unique nationwide project that is bringing a diverse group of individuals and organizations together, groups that do not usually agree on many issues. This is an unprecedented effort to raise awareness about the plight of the uninsured in America. A total of 140 national organizations representing business owners and labor unions, doctors and nurses, insurers and consumers, and every other point on the healthcare issue have come together, making the most significant nonpartisan educational effort on behalf of the uninsured ever. This is really impressive. So we will begin with Barney Speight. Barney is the Director of Public Policy and Government Relations with Kaiser Permanente's Northwest region. He's been involved in Oregon and Northwest healthcare policy for 25 years. Recently, Barney served as Administrator of the Health Plan Policy and Research Office for the state of Oregon. In that role, he advised Governor John Kitzhaber and the Legislative Assembly on Oregon's programs to expand health care coverage. Prior to joining the state, Barney held a variety of executive and policy-making roles in the private sector, including Regents Blue Cross Blue Shield of Oregon, Legacy Good Samaritan Medical Center, Oregon Association of Hospitals and Health Systems, and the Oregon Medical Association. Barney served as co-chair of the Oregon Public Employees Benefits Board and on the boards of the Foundation for Medical Excellence, Oregon Coalition of Healthcare Purchasers, and American Heart Association, the Oregon affiliate. His public service roles include Oregon Genetic Research Advisory Committee, Oregon Health Resources Commission, and several advisory committees on health insurance reform. Clearly, Gary's pretty informed on this issue. Since September 2002, Alice Dale has been the president of the Service Employees International Union, Local 49, here in Portland. They represent 6,500 private sector health care and building service workers throughout Oregon and Southwest Washington. Alice is a vice president of the Oregon AFL-CIO Union. She was the executive director of SEIU Local 503, the Oregon Public Employees Union, for 17 years before agreeing to serve as the trustee and the new president of SEIU Local 49. She was legal counsel for SEIU Local 503 prior to her appointment as executive director. Alice is a strong advocate for working interests and building activist-based member-run unions that combine representation, organizing, and politics to maximize workers' voices in the workplace and the community. Please welcome our guest speakers today.
Thank you very much, Susan. It's a pleasure to be here today, and it's also a real pleasure to be on the panel with Alice Dale, my colleague from the Kaiser Permanente SEIU Labor Management Partnership. I thought what I would do today is talk about three aspects of the uninsured. One is to give you some Oregon data and comparative data fairly quickly, but there is a new study coming out from my old office in the state government, and they gave me a couple of early indicators to help me make the speech timely for all of you. And then I'd like to put those numbers into some context from the perspective of the provider community, the insurance or health plan community, the purchaser community, and employees who are covered by private sector coverage. And then my colleague Alice will talk about it from both the labor and the individual perspective. There's also a survey, a national survey that I will highlight during this, and when I get to the national survey, it's available at the back table. Oregon has done for about 10 or 12 years, every 2 years, what's called the Oregon Population Survey. And it's a broad-based survey that looks at a number of areas of Oregon life, and one of them is healthcare coverage. And so we have a very good tracking system since about 1990 of responses to the question, have you been uninsured during the last year? The 2002 report, which was completed in the fall of 2002, will be released probably next week. And so I'm grateful to the leadership of the Office of Health Plan Policy and Research for sharing these with me so that I can share them with you. But the overall uninsurance rate in Oregon for 2002 was 13.96%. Let's call it 14%, representing almost 472,000 Oregonians who are without health and coverage, either from the private sector, public sponsorship, or self-paid individual insurance. This is a statistically significant increase from the 2000 survey, which indicated that 12.3% of Oregonians were without insurance. So you can see we've almost gone up almost over 2% since the 2000 survey. The uninsurance rate in Multnomah County is almost 15%. Almost a point higher than the state average. Children's uninsurance rates rose for the first time since the start of the population survey in 1990. Our uninsurance rate for children under the age of 18 is now a little bit over 10%, and in 2000 it was 8.5%. Hispanics continue to lead. It's an unfortunate way to put it, but the uninsurance rate with over 30% uninsurance rates in the Hispanic community. And men continue to outnumber women in uninsurance rates, 56% compared to 44%. So those are very current figures for the state of Oregon, and that's our state's perspective to the 41 million figure nationally. And I think it's a good indication, an unfortunate indication, of why this week has been bipartisan, across large interest to try to dramatize the importance of the uninsurance problem. Because I've been involved for so many years in Oregon health policy, I wanted to put this into some context for myself, because I've witnessed, I played a part, as many of you did in this room, of the development and implementation of the Oregon Health Plan, and not just the Medicaid reform, but other aspects that actually, if you recall, there were 7 states that could not wait, and we were among them. And our uninsurance rates statewide runs something like this. In 1990, 16.3%. In 1992, 18%. That's coming off the 91 recession. 1994, 18%, 92. 1994, 13.6%. The Oregon Health Plan was implemented in February 1994. 1996, 10.7%. 1998, 11%. 2000, 12.2%. And then, as I said, 2002, 13.96, 14%. So we've gone like this, and now we're coming back up the other side of the mountain, unfortunately. And the very low rates, the historically low rates of uninsurance that we saw in the 1994 through 1998 period were really a combination of two factors. One was the Oregon Health Plan, which broadened access to sponsored health insurance for low-income people. And the other was a very strong economy in which the private employment sector actually grew faster than any public sponsorship. 3/4 of the reduction of the uninsurance rates in the mid to late 90s were in fact of a thriving economy, employers, shortage of workforce, and more and more employers were offering health insurance coverage as both a recruitment and retention. Unfortunately, all of that has changed, and I won't get into it. We all know what's going on with state revenues, and we also know what's going on with the economy generally. Those are the statistics, but what are the implications from a rising and significant and worrisome level of uninsured in this state, in this city, in this country? I'd like to just briefly talk about it from 3 or 4 perspectives. First, because I've spent a lot of my life working for and on behalf of healthcare providers, let's talk about the provider perspective. Let's start with physicians. When a family or an individual who's been seen by a physician for several years, they suddenly become uninsured and may not have the wherewithal to pay for everything, many, if not most, physicians in this state will continue to see as many as they can. But they have businesses to run too. And they have to balance this precarious mix of Medicare, and we've seen a lot in the paper recently about what Medicare reimbursements are doing to physicians, Medicaid, commercial rates, and uninsurance. And so to some extent, they have to ration who they're going to see, how many they're going to see, and it may be based on those who are the most vulnerable. But clearly, what we do know is that in these times, access to physician services, but primary care services become very difficult if you're not sponsored. Safety net clinics. The safety net, which is a phrase used in healthcare to cover everything from county clinics, county public health clinics, to not-for-profit clinics that serve both Medicaid and unsponsored folks. The safety net clinics in eras like this are swamped and overwhelmed with needs that can almost be overwhelming relative to their staffs as far as being able to provide primary care access at any time of the day. And I think I've talked with people who run safety nets and represent the safety net in Oregon, and they've been through this before in high unemployment times and high uninsurance times, but these are very worrisome times for them, and the safety net is an extremely fragile backstop for healthcare for many people. And lastly, hospitals. Hospitals are the providers of last resort, particularly in a legal sense. The emergency department of a hospital for the uninsured, in fact, in many cases becomes very costly primary care because they have no other place to go. Our emergency departments in community hospitals throughout the state are witnessing dramatic increases in service levels compared to the fall of emergency level coverage when the Oregon Health Plan was implemented in 1994. The statistics 1994, 95, 96 actually saw a decline of hospital emergency room use, and it's attributed primarily to the fact that primary care access, much more readily available primary care access in much less costly venues was available. So the provider community does what it has to do, does what it can do to address the needs of the uninsured, but as by the very definition, the fact that they're uninsured and they're unsponsored, then they're not paid. And those costs, what happens to those unfunded costs of the uninsured? Well, let's start with the health plans. The Regents Blue Shields, the Kaiser Permanentes, the ODSs, the Providence Health Plans, and others who contract with providers. The first thing we will see is in our contract negotiations, providers generally, but in particular hospitals, will be indicating that the rise in uncompensated care costs are part of the costs now that we have to bear in our contract rates. So they begin to trickle down. The story I'm about to tell you is going to be a cascade of the costs of uncompensated care. They cascade first into the health plans through contract negotiations. And the size of what's shifted or transferred into the health plan varies from hospital to hospital based upon its service mix. But we do know that some, if not all of that cost shift does get transferred into the commercial sector and into the private pay sector. Medicaid doesn't recognize the costs of uncompensated care, nor does Medicare. So there's only a limited place for hospitals and other providers, if you will, to shift those costs. We, in the health plan business, Kaiser Permanente and the other distinguished companies I've talked to, sell healthcare coverage in the market. And those increased costs get passed on to purchasers, whether they be corporate purchasers or individuals who buy private policies. And as purchasers will have you seen in the paper and you'll hear from them, they have been witnessing double-digit increases in healthcare costs over the last 3 to 5 years. And in my reading of the national trends is that there's continued that will continue. Part of that cost increase in the last year or so and into the future will in fact be the cost shift. The cost declines we saw in healthcare in the mid-90s were associated with the Oregon Health Plan taking, if you will, the cost shift out of the commercial dynamic, and so there's less unfunded care to be shifted down. I think we're going to see a reversal of that, and it will certainly be a contributor to the cost of care that businesses pay for, and ultimately it reaches us as individuals in one of two ways. Those costs for higher commercial insurance are either transferred to us via what our employers may require us to pay in deductibles and co-insurance and co-pays, or in premium share, the amount that we may have to pay for our own coverage or for the coverage of our dependents. If the employer, and not many of them can sustain these double-digit increases year after year, most of them are doing some cost shifting to their employees, but if they couldn't, to the extent that they can raise prices, the prices of the commodities, goods, and services they produce, the cost of the uncompensated care leaks into that pricing structure. It's much more difficult, though, in many sectors, particularly the small business sector and in those companies in international trade, to just be able to pass those costs on in the price of a car or a loaf of bread or whatever. So to some extent, it's like everything else in the American economy. Ultimately, the buck stops with us as consumers, as individual employees and consumers. And so the cost of uncompensated care is built into the care that you and I get through the sponsorship that we have in the commercial market. And it's not just that this cost is a hidden tax. One could make an argument that the cost shift is a fairly efficient mechanism because there's not a lot of additional bureaucrats or accountants sitting around figuring out how to do it. It just happens within the economics of the healthcare market. But the problem with the uninsurance rate and cost shift is not only is it a hidden tax so we can't manage it, the uninsurance problem makes people get health care, I think, in the most unsystematic way and in an inhumane way. It's not very cost effective to go to an ER for the flu. There are less costly and more efficacious ways to treat that. It's not very wise to let a healthcare problem that an early intervention could have mitigated hospitalization, and without that early intervention, there ends up to be a surgery and perhaps an extended hospital stay. So we end up paying for care that's, even the care that's gotten appropriately for those who are uninsured, it's not efficiently organized or systematically organized, because it has to be, if you will, gotten on the come, where you can get it. And the first point in most communities is either through the emergency room or through safety net clinics. One last thing I'd like to mention, that for an urban audience, we don't necessarily sense this so much, but for hospitals that are in rural and frontier communities, the rising uninsurance rates can actually make the difference between survival or not, because most of the hospitals in rural Oregon, in eastern, southern, central Oregon, the small 50-bed hospitals, have such high Medicare and Medicaid mixes that when a significant portion of their service area becomes uninsured, their ability to make a bottom line and keep open is threatened. And I think that's going to be one thing that we really need to watch. Let me conclude with just some remarks about the survey that was done for the Cover the Uninsured Week. It was done by Public Opinion Strategies. I'll just highlight some of it, and again, the survey is on the back table on the way out. Of the 5 healthcare goals tested, the most important for business leaders is making healthcare more affordable, 51%, that was the top goal, followed by providing basic health insurance coverage to all Americans, 28%, and then it really scales down relative to quality and others. 8 out of 10 business leaders say that the number of uninsured Americans will increase over the next 6 months. And 7 out of 10 believe that the number of uninsured Americans will increase over the next decade. We read something about Oregonians being pessimistic. On this one, it sounds like everybody is pessimistic. Half the business leaders report that they're having significant problems keeping up with the cost of health insurance premiums. No surprise, we've heard lots about that. When asked what % employees' out-of-pocket costs for premiums have increased this year compared to last, business leaders report an average of 14%. So there's going to be more and more of if you will, the cost of health insurance borne by us as consumers. And for those of us that are in middle or upper middle class, that's one thing. For lower wage workers, that transfer of costs can be devastating. Business leaders project, and this is the one that I find most scary, business leaders project their company's healthcare costs will increase by an average of 18% from 2003 to 2004. And they believe that those types of increases will continue into the future. I'll stop there because a lot of it is old news, but it just reaffirms that, one, I believe there's a crisis in American healthcare. I believe it's playing out most severely in the uninsured, and the uninsured can be any of us based upon what happens to employment-based coverage or whether you no longer qualify for public sponsorship, for example, in Medicaid, because many state Medicaid programs, and several of us in this room are working on what's the Oregon Health Plan going to look like in 2003, 2005, are going to contract. The number of people they're going to be able to cover is going to get smaller. So not good news, but I appreciate the interest of all of you, and I appreciate the sponsors of this Cover the Uninsured Week, because I think the goal of this week is not to argue or debate the possible solutions, but to really put the problem in the context so that we can all appreciate it and begin to think about it. Thank you, and I look forward to answering questions.
Well, I too would like to thank the City Club for having this forum today. I think it's such an important issue across the country and in Oregon, and appreciate all of you being here. I'm pleased personally to be here to help bring some attention to the plight of the 41 million Americans who have no health insurance in this country. As Susan indicated in the introduction, SEIU Local 49 represents workers in Oregon and Southwest Washington. 2/3 of our members are healthcare workers. 1/3 of those are building service workers, mostly janitors, low-paid workers. The Service Employees International Union is now the largest AFL-CIO union in the country, 1.4 million members, and the largest AFL-CIO union in Oregon. It's also the largest healthcare union in the country. And at SEIU, we are totally invested in trying to find a solution to the crisis in healthcare that faces American workers. I was in contract negotiations on Wednesday of this week in Corvallis with Good Samaritan Regional Medical Center. And the fact is, at the bargaining table, we face as much concern over healthcare costs now as we do salary. I've been bargaining for 25 years, and it used to be that healthcare was an additional piece we needed to make sure we put in at the end on economics. And now, of course, costs as much sometimes as our entire wage package. I asked our bargaining team members to assist me in just identifying some examples of how healthcare services were really a problem within the current bargaining unit there, or within the Samaritan Health System overall. And these are some of the stories that I got. Leslie Rogers, who's a receiving clerk at Lebanon Community Hospital, which is part of the Samaritan Health System, is married to a man who lost his job 2 years ago. He was a truck driver. As a result, on one income with their 2 children, they couldn't afford to continue to pay the $200 a month copay or premium to provide family health insurance, so they canceled it. Her husband began developing some neck problems. It turned out he had a bulging disc and needed to have surgery. They paid for the medical visits and for the tests associated with that out of pocket. But they were eligible for the Oregon Health Plan, and so most of the surgery costs were paid by the Oregon Health Plan, which again harkens to what Barney said, which is that, we pick a lot of that up through public services. But the fact is, the family had to declare bankruptcy because of their medical bills, and will in June lose their home. The irony of this is that Leslie's daughter, an older daughter, now works at a production facility in Albany where the medical insurance is fully paid. Terry Thiel is a CNA who works at Good Samaritan in Corvallis in the cardiac unit. She's been a CNA for 4.5 years. She had gained custody of her grandchildren in September, but had a very difficult time supporting them on her salary. It turned out that she canceled a cardiac test in September because she couldn't afford the copay, and she died a week later. Another example of a worker at Good Samaritan, Ina Coronado, is an OB tech. She's worked at Good Sam for 5 years. She has diabetes, but because of the copay on prescription drugs, she only gets insulin for half the time she needs it. She waits for her next paycheck, and she purchases the rest of her insulin. I could go on, but I will stop. The fact is, the statistics are sobering about the number of people who do not have health insurance and the reality that they live sicker and they die earlier. And they're real people. Uninsured adults are 4 times and children 5 times more likely to use the emergency room as a regular place of care. Barney talked about what that means. It's very expensive. It's not the right way to treat people. People without health insurance are 70% more likely to be hospitalized for conditions like diabetes, hypertension, pneumonia, things that should be treated in a doctor's office. The burden of medical care without insurance stresses families emotionally and financially. 2/3 of the uninsured live in a household with a full-time worker. Health insurance is unaffordable for most uninsured families. Right now, 1 out of every 11 children in Oregon does not have health insurance, even though many of them have a parent who works full-time. Now, Barney just updated those statistics, and so it's slightly worse. 1 out of 5 parents of uninsured children does not allow their child to participate in athletics in school for fear of being injured and being unable to afford health care associated with that. A study that was just released by the Institute of Medicine found that the adverse effects of the uninsured have spillover effects on community health care institutions and providers. And the report finds that communities with higher uninsured rates have poorer access for health care services for people who are insured as well as the people who are uninsured. for the very reason that they access the system in ways, for example, with emergent care. I look at Heather Knight on our board, who works in the emergency room at Emmanuel Hospital. They access the emergency room rather than going to a doctor. And that means people who need emergent care can't get it as quickly as they need it. When people are unable to pay their medical bills, it increases the cost for everyone. In 2001, federal, state, and local governments covered 85% of the $35 billion spent on uncompensated care in this country. The fact is we all pay for it, either through public services or we pay through it through increased costs and premiums. When uninsured people do access the system, usually, as I've said, at the most expensive point, which is in the emergency room. So who are these uninsured? Probably not a lot of us in the room today. But there are a lot of our friends, there are neighbors, waitresses, maybe the person who served you coffee this morning, maybe the janitor who cleans your building. I can tell you, representing janitors now, that roughly half the janitors who clean some of the most expensive real estate in the city of Portland do not have health insurance. Maybe it's the child of the CNA who helped you when you were a family member was in the hospital last time. Or maybe it's a home care worker who provides in-home services so someone doesn't have to live in a nursing home. In each grouping of workers that I've just mentioned, these people are more likely than not to have no health insurance at all. Our system leaves people falling through the cracks every single day that most of us think are people who would have some type of health insurance. I think probably those of you here know that in the United States we spend more on a per capita basis on health care than any other developed country in the world. And we also leave more people who are full-time workers uninsured. So while at least, and I had written in 441,000 Oregonians, but now I'll increase that to 472,000 Oregonians, are currently without insurance. A new study indicates that the number is a lot higher. Another study, Families USA, finds that 890,000 Oregonians were uninsured for at least 1 month during the last 2 years. So you take that statistic and nearly double it over a 2-year period, and it becomes really quite astounding. Over 75% of those people went without insurance for 6 months or longer. It wasn't a 1-month window in which they didn't have insurance. And 2/3 of them live in a household with a full-time worker. The incidence of uninsurance is not equal. Some of the statistics that Barney mentioned, I could add that 50% of people with incomes between 100 and 200% of the federal poverty level are uninsured, 50%. More than 50% of the Hispanic population has been uninsured during the last 2 years, 40% of African Americans, and 50% of people between the age of 18 and 24. The fact is that 465 Americans lose health insurance every 2 hours. So from the time you left your office to come here and have lunch and participate in this forum and go back, roughly another 500 Americans will have lost their health insurance. So why do SEIU Local 49 and Kaiser have a partnership that includes fully paid family coverage? Because we recognize that health care is a problem we share as workers, as employers, as members of this community. In failing to acknowledge that, and a lot of employers don't, really doesn't solve that or change that reality. Because Kaiser and the 65 unions that are part of the coalition of Kaiser unions recognize that workers are more productive day in, day out, when they don't have to worry about if they are sick or a family member is sick, whether they can get quality health care services. We recognize that in an employer-based health care system, which is what we have in this country and what every bit of polling shows Americans want to continue, should provide comprehensive care to workers and to their families. And in return, we are committed as unions to engage with Kaiser to help pay for benefits by running a top quality program with real partnerships that identify and promote efficiencies and excellence. And these qualities make Kaiser, we believe, and they do too, more attractive, not less attractive or less competitive in the marketplace, but there is a real cost to doing that. So we face a real crisis in healthcare in this country. Many of us have been grappling with this for a number of years. And what we see is more than not, costs keep getting shifted to workers who can't pay for them. 20 years ago, 85% of employers provided health care benefits. Today, 62% do. And it's getting worse. So we need to find political solutions, and many of these problems require joint efforts from business, from labor, from community groups. The fact is, a lot of these require solutions that are much bigger than anything we're currently looking at, either locally or at a national level. There is a handout in the back on the table that I would ask you, if you're interested, to pick it up on your way out. It's by Oregonians for Health Security, and it identifies a number of the legislative issues right now that the Oregon legislature is dealing with. And I'll just, in 3 categories, indicate they deal with reducing prescription drug costs, expanding coverage, and eliminating fraud in the system, and focusing on the pharmaceutical benefit managers, which is a group that everybody should educate yourself about because it's a very serious problem. So with that, I'll stop. Again, appreciate being here and happy to answer questions.
Thank you very much. I really appreciate the opportunity for City Club to tag along with the Uninsured Week programs, because we have an extensive radio audience, and that is able to provide information for people all over the state regarding this very urgent issue. One thing that I would like to ask, given that it's quite clear that people, the working uninsured, are putting a stress on the emergent care providers, and that it's costing a great deal of money to provide that care, is there a way for small employers, and I believe that the small business represents something like 70-some% of the business in Oregon, is there a way that small employers and the working uninsured might be able to find insurance through a partnership of healthcare insurers who recognize that by providing some sort of joint coverage that for this kind of worker, that it would ultimately reduce overall costs? So I'm hopeful that you can provide some insight on that, and also talk a little bit about small business owners.
Okay, Corleen, thank you. In the survey that I referenced that's on the back table, there are some interesting statistics about the differences between large, medium, and small employers. Oregon, as Corleen indicated, is a small employer state, and small employers generally are a much more fragile portion of the business community just because of their mere size. One of the statistics I thought was interesting is that nearly 96% of all large businesses pay at least some portion of the health insurance benefits for dependents. Medium size, it's about 72%, and small businesses is about 59%. And what that tells me is that small businesses have a much more difficult time confronting these increases, particularly over time. The statistics about the number of employers who no longer offer insurance is telling, but there's only so many places that small business can go. They can restrict the benefits, they can raise co-pays, and then they can raise premium share, particularly premium share for dependents. Most of the survey data, this most recent survey, shows that most employers, including small employers, do not want to drop coverage. I was at a conference, or at a meeting yesterday, and spoke, and a small business person was actually telling the group their strategies. They don't want to drop coverage. That's the absolute last thing to do. As to what's the solution to this, or at least a model for a solution, I guess I would point to the Family Health Insurance Assistance Program. It's a relatively small model that started as a part of the Oregon Health Plan in 1997. And in the most recent negotiations with the federal government for a new waiver, we now actually have federal match. But the concept behind the FHIA program, Family Health Insurance Assistance Program, is this. If an employer offers us health insurance but has, for example, low-wage employees that can't pay the full premium either for themselves or their dependents, if the employer puts his or her money on the table, the employee puts a small portion of their money on the table, then the state and the federal government, based on an income level, would put the balance on the table. The purpose being is to make group health insurance work, particularly in small businesses and particularly in businesses that have a lower wage base. It's, as I said, it's relatively small. There's probably about 20,000 people that are involved in this, and that's individual and grouped together. But the point being is that I think it's a model of the future when it was developed in 96, 97, to try to begin to look at how do we help the employer and the employee make employer-sponsored coverage work. We're clearly going to have to do things differently, and I think there's clearly a role for government to help particularly low-wage employees participate in group insurance.
I'm Ted Falk. I'm chair of the City Club's Healthcare Issues Committee, and many of our members are here today. We're working on a report which we hope to publish in the City Club Bulletin sometime in the next few months on the healthcare safety net in the Portland area. So I wanted to ask Barney and Alice about a little bit about a question about the safety net. It fits nicely with the metaphor of today's program that we have the health insurance tightrope, and then there's a safety net for people who fall off the tightrope. But in public funding discussions, these two parts of the system sometimes get disconnected. So my question for you is, in the unlikely event that you were Governor Kulongoski and you found $10 million in your budget that was dedicated to increasing access to health care, how would you allocate that between increasing health insurance and providing better funding for the safety net, and why would you make that decision?
Go first. I'll start.
Okay.
It is unlikely that I would be Governor Kulongoski. He's got more hair and he's a better bowler, I know that. But it's an excellent question, and it's a question that takes me back to when I worked for state government in the midst of trying to create, if you will, a public sponsorship program, if you will, public insurance program through the Oregon Health Plan. And I would answer it this way. I think I would probably put 80% of it into the safety net, and I put the other 20% into insurance programs to get as much insurance coverage for kids in low-income families as possible. And I would do it that way is because I think the safety net, expanding and strengthening the safety net, is going to be a critical piece of until we get to a larger solution, a larger national solution. It's going to be a critical piece to make sure to preserve and expand primary care access for families, for kids, but particularly for working adults. And let me give you an interesting, Ted made an interesting comment, because I think he's right. Sometimes the way legislation and these concepts in healthcare are looked at from a policy point of view, there's those folks on the insurance side of the road and the others sitting on the safety net side of the road. But I'd point to the state of Washington as an excellent example of where they're actually thinking systemically. Governor Locke, unfortunately, had to propose cutting 56,000 adults from the basic health plan because of rising costs and plummeting revenues. But in making that really tough decision, he also made a countervailing decision of putting $25 million in expanding the Washington State safety net. So I think it's a clear policy recognition that if insurance mechanisms, publicly sponsored insurance mechanisms, are not sustainable or can't be as sustainable for as many people, then we clearly we need to create alternatives and strengthen the alternatives in the public and not-for-profit safety net delivery systems.
Actually, am in large agreement with Barney with regard to how I'd spend the money. I think that there's no question that for the long term, we have to figure out, I think, first how to make sure all children have health insurance. That ought to be our first priority. The Oregon Health Plan was making substantial, headway in doing that. The financial crisis is very serious and very real, and so it's not going to happen. But I think that expanding the safety net is a critical first course decision, and I think long term, since we're probably going to have a combination eventually, we find a solution to this, a system that has private insurance as well as a safety net. We have to figure out probably how to expand that safety net to cover vulnerable populations that aren't going to have access through employer-based systems. So that would be my first priority.
Guinevere Milius, City Club member. My question has a bit broader scope. When you look into the future of national health care, and what do you see? And if this is truly a crisis that we're in, when do we hit bottom? Or what point do we move our leaders, both national and local, to start thinking of solutions on a national and systemic level?
question about when we hit bottom is a very curious one. My personal feeling has been, and I've been working on the healthcare issue pretty intensely for about a decade, is that not until middle income and upper middle income Americans have a great fear about losing health insurance, or have a lot of family members who've lost it, if not themselves, then it moves into the public consciousness in a way that we can do something. And it is definitely there. There is no survey that doesn't show that Americans view this as one of the highest priorities in terms of areas in which they feel economically insecure. So I think we're there. The crisis is there. And in terms of solutions, I think my earlier comment that I just made about we probably will have a combination, because Americans don't seem to want socialized medicine, and the Canadian model and the British model have been vilified pretty intensely in this country, which is unfortunate, I think, but I'll accept that reality. Then we probably have a combination of an employer-based system that also has an expanded public health system. In the state of New York, for example, SEIU Local 1199 New York, with the Hospital Association of the Greater Albany area, New York City and Albany area, they moved a program to cover all children, and they did it through an expansion of essentially their equivalent of the Oregon Health Plan. And so, it's interesting. I think, not that necessarily is a model for the rest of the country, but I think it does show, that there's a possibility that we just expand the public system and then have an employer-based system, which I guess I think there needs to be something like the pay-or-play system. Employers either provide it or they pay a tax. One of the initiatives that you'll see, one of the legislative items in the legislature now, is that all employers pay a tax, and if they provide insurance, then they get a credit. Eventually, there has to be some type of system in which everybody who's employed gets coverage.
I would agree with Alice, and I smiled when she said when the middle class or upper middle class. I actually used that same line last night in another address, because in my view of the politics of this is that when the center of the American class system begins to move politically, then things begin to happen politically, and I think we are threatened. I'm 57 years old with two kids in their mid-20s. My daughter is married to a Coast Guardsman, so they've got federal coverage. My son, 23, was on coverage as long as I could keep him on my coverage, and now he's got a job with coverage. But I worry, what if he gets laid off? Or what if he makes a jump for a job, at 23, I was 23 once, I can get $10,000 a year, but there's no more benefits in it. Then I'm going to be worrying about who's going to be paying the hospital bill. I mean, I'm not legally obligated to, but I would feel really bad to have him have to declare bankruptcy at 25, 26 years old because he had a $25,000 or $30,000 hospital bill. So I think this is high in the consciousness of all of us, unlike it several years ago. And I believe the solution ultimately will be a hybrid. I agree with what Alice says. I think one of the issues that I've always been perplexed with employment-based system, and I'm a believer of it, in it, is that unlike the employers and employees pay an unemployment tax, so that at least tides us over if we get unemployed. And when I got in health insurance 25 years ago, I was trying to be a marketer. Why don't we add 2 or 3 cents or whatever the actuary says, because that in a defined event you could actually have your COBRA coverage paid for 6 months because you've pre-funded it. Why don't we pre-fund some of these gaps that happen, because we are a very mobile society. We all want to move between jobs to move upwards. But the problem with this job lock sometimes is that you can't move because you don't want to leave the health insurance coverage, not necessarily for the worker, but for the dependent. You might have a child that has a disability or whatever. So I think we can make employer-based coverage work a whole lot better. We have to be a lot more thoughtful about how to do it. And I think we're going to have to be courageous about saying, if that's the system we want, then everyone's going to have to step up and play, one way or the other.
Bill Parrish, City Club member. Thank you for all your great work you're doing on this issue. You can tell it's complicated because many of us are using notes to ask questions. One of the more interesting things probably in the last year that really dramatizes this was probably the Portland Public Schools when they fired all the janitors, the custodians. And my question is to Alice. I know it's a real difficult situation, but here you had a lot of longtime employees, many people that were members of your union, SEIU, for 20, 25 years, and they were all fired. And their jobs were subcontracted out to another company. And that company, interestingly, those very same people are also members of your union, paying the same union dues. And if you look at the health care coverage, the custodians, they made big concessions, and for some reason, Steve Goldschmidt and the district administration decided that the concessions weren't enough. And the way it stacks out is the current employees that work under the subcontractor that are union employees get 1/4 the health care coverage and literally no pension. And my question to Alice is, I know it's a really difficult situation, everyone's trying to cut costs, but what do you say to all those custodians out there that are fighting to get their jobs back who worked for the school district 20, 25 years, and they basically got, Barney, 2 weeks, and that was it. They're uninsured after 2 weeks. What do you say to all of them that paid SEIU union dues many times for 20 years?
Well, I think it's a pretty sad situation where one of the ways in which the Portland Public Schools chose to save money was by contracting services so that they went to workers who earn substantially less money in terms of pay, have just a pittance of the pension plan they had, and substantially worse health insurance. There's no question. It actually is Local 140 of SEIU. We are Local 49, so they're public sector school janitors. Local 49 is private sector custodians and healthcare workers, and Local 503 is public employees, state, city, county, and home care workers, etc. And so both Local 49, the local that I'm president of, and Local 503 were involved in waging a campaign, a strong campaign, to try to keep those jobs public. But we lost that fight. And the crisis in public schools is very serious. We understand that. But what we say is this. We think any of those janitors who can get jobs back in, good paying jobs, they should do that. Portland habilitation by statute was given really priority in terms of being able to bid on that contract. And they're under the master janitorial contract, which opens this spring in Portland. And those janitors have less than fully paid employee-only health care. And it's not just PHC. It's also all of the union contractors. There are 11 in the Portland area. One of our big issues, and we've met with the contractors, all of them, and talked to them about getting fully paid family health care. That's a very high priority for all the reasons we've been talking about. It was an issue in Fred Meyer bargaining we raised this last year and moved from employee-only health care to fully paid family care. And I, applaud Fred Meyer for doing that. Not all grocery store chains do it. Certainly Walmart doesn't do it, and our brothers and sisters at UFCW are in a big fight over that. But it's a very unfortunate situation. We've always believed that contracting out should never be done on the backs of workers, and that's what I think happened.
Sandy Marin, City Club member and administrator for the Oregon Nurses Association, one of the partners for covering the Uninsured Week. My question is, the Robert Wood Johnson Foundation spent millions of dollars to establish this cover, the Uninsured Week, publicize it so everybody's aware of it. Do you see them or some other agency or organization making a similar investment on coming up with a solution?
It's a good question, and I applaud Robert Wood Johnson and the other sponsors. And in many of my previous lives, but particularly when I was with the state of Oregon in health policy, Robert Wood Johnson provided the state of Oregon and generally, and my office specifically, with wonderful grant funds to be able to do some, I think, really interesting policy work. I don't know whether they're going to get into the solution. They may get into the solutions in the sense of holding policy forums, of looking at different approaches. And I think that would be valuable, because I think one of the things that has to happen in the dialogue about this, we're not going to get anywhere if it's an ideological, partisan bickering with lots of. Remember the ads on TV during the Clinton? I mean, that's not the kind of way that we're going to get Americans to understand what the problem is, and then what are some rational options. And I think doing national grassroots community kinds of discussions on 2 or 3 different models and getting feedback about how that would work would be really helpful. Now, I can say that, and we can probably all think that that's really pretty straightforward, because that's exactly what we did in Oregon in the late 80s and early 90s. But I don't think it's impossible to go around New York State or Texas or any place else and have some meetings and lay out some different plans and let people think about them and test the ideas and then take those into the political arena. And that would be a valuable contribution for RWJ or any other foundation or corporations to be involved in. Is to try to frame a rational debate before you get to Washington, D.C.
Let me just add, too, I think there really is tremendous interest with foundations and groups interested in healthcare policy to try to help figure out a solution. And for the same reasons that middle-class families and more affluent Americans feel the crunch on healthcare, business is very committed to trying to maintain quality healthcare, having a hard time doing it. And so I think there is a coalescing of factors that make it more likely that we could do something. And I just think it really is when it's a bipartisan effort, when it's a labor management effort, when it is, the unlikely atypical allies who come together on these things, and it increases the likelihood it's going to happen, because in the end, people like our dear Representative Wu knows that, these compromises are very tough, but when we can get people on both sides of the aisle, so to speak, talking about we need a solution, then we're likely to get to one.
David Wu, City Club member, and more importantly today, a Kaiser Health Plan member.
Yeah.
Barney, Alice, you each referred to the high cost of health care as a major contributor to people not being insured and having access. We've tried cost containment in the private sector through managed care, on the public side by bringing down Medicare payments, and now with respect to both managed care and this Medicare system, we're going to blow through those efforts at cost containment. Do you have ideas, either one of you, about new cost containment ideas from here going forward, or are these the best that we can do, and do we try to keep on working what we have?
Thank you for that question, Congressman Wu, because it really does, I think, center the discussion of the solution where it has to be, and that is cost is the issue, access is the symptom of the failure to deal with that issue. And I've dealt with the cost issue and watched the cost issue over a couple of decades, and I'm both pessimistic and optimistic depending upon whatever I had for lunch. But let me deal with because I had a good lunch, I'm going to be optimistic. The issue in cost is partly cultural, and that is we expect a lot as healthcare consumers, and we believe too many people about what works, and we don't all know, including physicians and other caregivers, exactly what works and works well. Evidence-based medicine, and the more that we invest in evidence-based medicine, the more we invest in knowing what new technologies will do before they come online. Do they really add value to the healthcare cover, or are they just a new cost with marginal value? We've got to get a handle, because the primary, we can't change the demographic of an aging society. That is in a democracy, demographics is destiny. I learned that in Poli-Sci 101.
That's a good line.
But we have to get our hands around how we manage technology and bring it online rationally, and then how we inform caregivers about the use of that technology so that they use it appropriately, they have the confidence that when they order it or they don't order it for their patient, that it's based on strong evidence and not some detailer or some HMO telling them not to do it, the other telling them to do it for reasons that they don't feel comfortable about. So I think we have, and I'll tell you what the political side to that is And we tried it here in Oregon with the Health Resources Commission, and I served on it for the first 8 years. And that was try to evaluate new technologies and then answer the question, how do we diffuse them through Oregon? This is primarily hospital technologies. And you know who hated that process? Technology companies that are developing new technologies. Because if you get a new technology approved by the FDA as safe and efficacious, and then you get Medicare funding for it, Katie bar the door, you got your return on investment in 5 years, and it'll take us a decade to learn how to use it in healthcare.
I'm sorry, that good question took us right up to the end. I apologize to the last two questioners. This was a very, very informative program. Thank you all. City Club is adjourned.